We have some rationales for our studies. And the first rationale was that the risk from air pollution are now far greater than previously thought or understood, particularly for heart disease and stroke. And as you can see, that has been admitted by Dr. Mary Neera, director of WHO, recently. And also WHO, in their recent report on health and air pollution, said that outdoor air pollution can cause up to 40% of ischemic heart disease and 40% of stroke. Another study rationale came from another large study, which now are initiated by NIH and NIA. It's about geographic disparities we have in the US in health outcomes, in disease rates, in mortality, and as a result, in life expectancy. And in announcement of this RFA, they said that existing studies on demographic, social, economic, behavioral, and access to medical care factors still cannot explain why in the US we have more than 3 years differences in life expectancy between the states. And environment exposures was not one of often considered in this kind of analysis factors. So our preliminary results of our team showed that when we analyzed US states with the best life expectancy and the lowest life expectancy, we really saw the difference, more than 3 years. And when we added sex and race characteristics, we see that for total it's red number 1.2. It's how that reduced the geographic disparities. Then we added another CES variable to this study. It's also reduced even more. And then we added environment factors, which in this study was represented by air quality. And we see that it's reduced even more this heterogeneity in the US. So that was another rationale to look at the very common diseases. Other studies, like this famous study of Zanabetti from 2009 of 112 US cities, showed correlation between air pollution and cardiovascular disease mortality, especially for particulate matters 2.5 and increase in heart disease and stroke deaths. And recently it has been shown that it looks like there is no safe threshold for air pollutants levels and health effects. So even if we're living like in North Carolina, and Sheila Holman will tell more about it, in pretty much good situation right now with air pollution, for some of air pollutants, we still may have some improvements, even if we'll reduce the air pollutants level further down, even when it's below the standards, current standards. And in our previous study on air quality and respiratory death rate, we showed the beneficial impact of air quality improvement in North Carolina and reduction of emphysema, asthma, and pneumonia mortality in residential populations. As to cardiovascular diseases, we will talk about right now, CVD in North Carolina causes almost 30% of all deaths, so that's a lot. And heart disease is the second, and stroke is the fourth leading cause of death. So, what is known about CVD and air quality relationships, for example, in North Carolina? So, we have certain CVD trends in North Carolina. We also have air pollutants dynamics in North Carolina. But how from this information we can tell something about the role of air quality changes or dynamic of air quality in changes in cardiovascular morbidity and mortality in our state? So let's look at this classic graph which shows how cardiovascular disease mortality changed with years. It's long historic data, and you can see in 60s it started abruptly, going down. And till now, scientists discussing what causes this turning point in reduction of cardiovascular diseases. And since it's been in 1979, as you can see in Bethesda, suggested this spectrum of factors affecting cardiovascular death and together causing this reduction. And you see here so many factors. It's different new treatments, it's diet change, it's blood pressure control, cholesterol level, exercise, social economic status, and many, many other. So that seems that all of them should be taken into account when we're trying to understand why certain disease going down. And you also see here environment. So it was suggested in 1979 as one of potential factors. And unfortunately, until probably recent decade, we haven't seen a lot of publications on the role of environment in cardiovascular diseases trends. So, how looks CVD in Health in North Carolina targets, 2020 year targets? So right now, we see reduction in cardiovascular deaths, and it's almost even gone a little bit down, red line, its target for North Carolina healthy people. We also see reduction in stroke death. It still didn't reach the target, but we have some years here. Also, what we see, so unfortunately, I cannot see from here. So it's just very sharp angle, and I cannot see what's on screen because it's so tiny that we're not able to open it in full. It's just tiny picture here. So it looks like it's hypertension. So we see that for hypertension, unfortunately, till now, North Carolina, we do not have such a good improvement as for heart disease and stroke. Also, we have here blood cholesterol level, which one of the risk factors of cardiovascular diseases, and we see it's going down, but it's still far from the target in North Carolina. And also we have some other factors in North Carolina, which also from this spectrum of factors affecting, which I showed before, cardiovascular disease rate. So this factor is just it's medical insurance percent. It didn't change substantially over years, and it's far below the target. So also it's primary care, access to primary care, it also did not change over time in North Carolina, and it's below the target. So it's also how people who visited their doctors with cardiovascular diseases got their prescription aspirin to prevent exacerbation of cardiovascular attacks. So we see that it's even going a little bit down, so it's below the target. And also it's cigarette smoking, which definitely is a risk factor for cardiovascular diseases. It's slowly going down, but it didn't reach target in North Carolina. So we have these healthy 2020 cardiovascular targets. But how now, over time, we can tell where is North Carolina compared to US in general and other states. So based on cardiovascular diseases dynamics, it's somewhere between, in the middle of all states. It's around, as you can see here, it's around US average. So United States, it's black, and North Carolina is brown. And what is good to see that recently North Carolina had heart disease rate lower than US average, as you can see. Stroke death rate, it's still a little higher than US average, but for heart disease, we definitely have this substantial improvement in our state. So What about our data? In our data, this is mortality trends in North Carolina for people aged 65 and older. And blue, it's the oldest group, 85 and older. Red, it's middle-aged, and black, it's 65, 74. So you see that all diseases, hypertension, ischemic heart disease, cerebrovascular, myocardial infarction, and stroke, going down. So also in our data, we see that hospitalization trends for these diseases in all age groups in North Carolina also went down. And that's similar results as we see in CVD hospital discharge rates in North Carolina from North Carolina Center for Health Statistics. So hospitalization rates for these diseases also goes down. What about dynamic of air pollutants? That's criteria air pollutants, sorry, I just noticed mistypo. So we see that air pollutants also going down since 1999 especially, and some of air pollutants like particulate matters, they're sort of like summer air pollutants, so they're high in summer, some of them gases high in winter season, but they definitely going down. And air pollutants like particulate matter, it's just to better understand. So we have that's hair, human hair, and small blue dots, it's particulate matter 10, and around them it's small red dots, it's size of particulate matter 2.5. In general, as I mentioned, we look pretty good in North Carolina, and Regine Shaler-Holman will tell you more about it. And we see that North Carolina is in green zone for particulate matter 10. But as to particulate matter 2.5, but it was 2009 paper. Around large cities, we still can see that North Carolina have red, orange dots, so it's like higher levels of particulate matter 2.5, especially around large cities. So in North Carolina, we have multiple policies that address air quality, as Bill Ross said. And we have criteria air pollutants and outdoor air, which have standards. And they're set at levels that protects public health with an adequate margin of safety. We hypothesize that cumulative effect of federal and state acts and regulation benefits the health of local population by reducing cardio and cerebrovascular as well as respiratory morbidity and mortality. We also understand that other factors, such as socioeconomic, behavioral, medical care improvements, also contribute to this cardiovascular disease trends. And that's just to show you, to demonstrate what Bill Ross recently said. It's a huge, long list of various acts, regulations in North Carolina. And with gray, I marked 1999 year and down, when the most effective we saw on air quality changes in North Carolina. So it's not like one or two acts. It's a long, long story. And also not only in North Carolina, but some impact from nearby states also, because we do not have like a wall around North Carolina, but that's in North Carolina. So what's about our study? People older than 65 years old. So that's the diseases we looked at. I mentioned them in previous graphs. So the data sets we used is individual level data on disease-specific mortality, emergency department visits, and hospital admissions. Also, it's U.S. Environment Protection Agency data on air quality and data on smoking from behavioral risk factor surveillance system. Our approach was county-level analysis for counties where we had monitoring of air pollutants. We analyzed associations between month-to-month overtime changes for age-specific death rates or hospital admissions or emergency room visits, and month-to-month overtime dynamics of air pollutant levels. Analyses were adjusted by age group, specific smoking prevalence, social economic characteristics, and also seasonal fluctuations of disease-specific deaths. We mean here sort of like administrative effect, because sometimes people are going, in autumn more to doctors because after vacation, all this stuff. So what does it mean? Like this approach, I'm just trying to illustrate it. It's not real data, it's just to understand better. So it's fluctuations. We see the same endpoint with the same starting point, but between these points, so likely it is a correlation on the right, from its left slide, and no correlation on the black slide. So we just looked over years on monthly basis for many years of correlations between diseases and air pollutants levels. So that's one of the results. There are a lot of numbers here, but in general, what we can see. For example, for air pollutants, CO, SO2, and 2 types of particulate matters, they showed correlations with outcomes, health outcomes, minus its mean reduction of air pollutants, reduction of mortality or hospitalization rates. So that's why it's with minus. We can see that myocardial infarction is ischemic heart disease. They have very similar patterns of associations, and we cannot see some clear associations with arterial hypertension. So even in some places it have negative association, which is with plus here. If we'll recollect now what we saw on previous slides on this trend, yes, hypertension really in healthy people 2020, it really has, even sort of like increasing little bit trend. But so that's not surprisingly that we haven't seen here these associations. So this analysis was adjusted by social economic factors, by smoking and seasonal administrative death impacts. And all results showed here had p-value less than 10 minus 6, so it's pretty strict, strong association. Cerebrovascular diseases, so we separately took stroke and we took also larger group cerebrovascular diseases to look how it will, what results it will show. So we see here also associations that cleaner, it's mean lower levels of these air pollutants is associated with lower levels of mortality and hospitalizations. That's regain for people older than 65. But then we decided that probably CVD prevalent also in younger people in North Carolina. And when we looked at some reports in North Carolina, we really see that both heart disease and stroke, which together, have a CVD term in analysis, so they both show for hospitalizations and for deaths up to 40%, it's among young people. So that's why we decided also look at younger people, younger than 65 in North Carolina. And that's our results for people aged 35, 65. And you again see that yes, we have here impact of better air quality on better myocardial infarction, mortality, hospitalization, better ischemic heart disease, cerebrovascular, including stroke, and we cannot see some associations for hypertension. When we compared older people and younger people in terms of correlations with improved air quality, we see that for heart diseases, more impact was on older people. But what is interesting that for stroke and cerebrovascular disease group, higher impact from improved air quality was on younger people. And here also probably we need to mention one seen that we also published a paper on minimization of heat waves. And we stress that young people, they like, outdoor activities, even in hot season, and jogging a lot. And some of them could be workers, occupational workers outdoors. And it's heat, steamy weather in North Carolina, plus high levels of particulate matters, especially in summer, what we saw on previous slides. And these people, as we can see here, they could benefit more from cleaner air if also we'll teach them about how successfully and safely behave to avoid strokes in younger ages. All these tables, they were probably a little bit difficult to understand, so that's why I decided at the last slide to show you example of how we can turn these large tables into something more real. So that's some examples of potential benefits of improved air quality in North Carolina, and that's annual reduction in death and hospital admissions since 2000 here. For example, for myocardial infarction and particulate matter 2.5, two different age groups, and we see how many deaths less and how many hospitalizations less we can now have because of lower levels of these air pollutants in North Carolina. So that's also associations with ischemic heart disease and stroke, and that's numbers. These numbers, we definitely understand that there are some other cofactors which we did not include right now in the analysis, but that was one of the steps of analysis. At this step, we can say one thing, that yes, it has effect. The next step to go ahead, what we're planning will be to perform, for example, partitioning analysis, which will help us to evaluate the contribution from multiple cofactors and the place of environment exposure, air quality, specifically for each disease, using data with individual health measurements like Medicare, where we can go information about contemporary treatments, which we cannot get from the data we're using right now. It's individual level data, but it's just outcome data. We also continue to perform the analysis on geographic disparities, even within North Carolina and between the states, the one I mentioned before, because from this study we also can understand which percent of contribution, for example, to cardiovascular diseases could be correlated with improvement in air quality. And what is also important, it's try to move to the step of medical cost evaluation, because if we can see here in North Carolina, stroke and coronary heart disease, overall hospital charges dramatically going up. And if we can have less hospitalization for these diseases, so that's also may have some thoughts to perform medical cost analysis. So we thank the people who helped us in this analysis. It's Dr. Igor Yakushevich from Social Science Research Institute, and we thanks for consultations, the specialists from the North Carolina Division of Air Quality, and thank Fred and Alice Stenberg for supporting this study with their philanthropic donation. So thank you very much.
Thank you, Leah. So one of the things that we had chatted about is in the initial study we had worked on, we thought about what would be an obvious disease associated with poor air quality, respiratory diseases. And in the U.S., actually the death rate from respiratory disease, COPD, over the past 20 or 30 years, oddly enough, has actually been increasing. So if you were able to show a decrease in this region, it would be quite interesting. And again, West Virginia was an index, Kentucky was an index state, and their death rates have been fairly stable. In this circumstance, so even at the state level, the state reductions were fairly clear. In this analysis, you have the underlying improving health from and reduction in morbidity and mortality from heart disease and stroke that is occurring across the country. That's also occurring in the Southeast and North Carolina, and trying to make the case that it's related to improving air quality seems like it's more challenging because it's perhaps not as dramatic. But the death rate and the morbidity from heart disease has probably more events, and now you're at the county level and maybe at the zip code level. What's the potential to either compare those regions of the state that have had high quality air for the past 20 or 30 years versus those parts of the state that have had improvements in their air quality, and looked at the event rates, comparing those rather than just looking at the county level associations? What is that opportunity, and what do you think that would do as far as your ability to have a narrative that it's, or isolating the improving air quality as the sort of the driver for this improvement?
Okay, thank you for this question. So actually, that's what Dr. Lally just mentioned. It's the part of this study I mentioned at the very beginning of presentation, when we take states with bad air quality, with bad health outcomes, with short lifespan, and we take states with good one, and we can take North Carolina. This state is somewhere between these two extreme characteristics, and we really could adjust by other factors and look at specifically at larger scale on different states what's going on. So that's actually what we're planning to do. We also can take like Medicare data with detailed records on contemporary treatment approaches to cardiovascular diseases, and like using cardiac specialized unit, care unit, and bypass surgery, and compare between the states. Moreover, what I can tell you that even in North Carolina, we have areas like eastern part and Appalachian part, which also have a little bit different characteristics on cardiovascular diseases and on respiratory diseases. So we also have what to do even within North Carolina, so to compare this. And with each this step of analysis, with each comparison of different regions within North Carolina or within United States, or using different data sets which provide us with some additional information, we can make the numbers of benefits more and more precise. Now we're somewhere in the middle of this, way, moving from step to step to make it more precise.
Yeah, again, I think the opportunity here is in this forum, this is all unpublished, and the idea is to continue to try to get others to be engaged in these types of analysis, because the collective opportunities are, for example, to bridge with some of the EPA data sets that exist. They have the CathGen analysis that Dwayne Cassio has been doing. There are other forms of data sets about cardiovascular events. Again, there may be interest in racial disparities and data sets that describe the differences in outcomes for different populations, and then trying to collect that data and then map the environmental factors on top of that data, may be useful. So I think that some of the intention of the presentations at this forum are to invite others to participate or engage or to think about strategies that could provide, more illustrative examples or more definitive evidence about the health impacts. I know the capacity that you have to look at a variety of disease states has increased because there are many diseases, and again, I think started out with respiratory disease and are looking at county level and zip code level events, but again, it becomes dependent somewhat on the actual events that occur in that geographic space, and then how best to utilize that data and draw some meaningful conclusions that would allow us to do the confirmatory studies, et cetera, et cetera. So, questions from the audience?
Hi, Xiaoxing from Duke University. Thank you for the great presentation. Can we go back to, I have a few questions. Can we go back to the slide with the exposure, hospitalization, and mortality correlation, the big table slide?
Which one?
The first time when it's not broken between the different age groups, but the first time when we saw that table. I think we need to go
Hospitalization,
forward a
this
little
one?
bit.
For hospitalization?
We can go forward a little more.
Forward.
Yes, this table.
This one?
Yeah.
But it's for age group 65 and older, so it's also broken.
Oh, okay.
We have older group and then separate slide younger group.
Because age is the effect modifier. That's why you
Yes,
into
it's,
two
it's
tables.
broken, yeah.
Yeah. So I really like this table. It shows many airborne pollutants. It also shows 3 different diseases. My question is that this table basically tells us, okay, air and is the association between the two. So my question is that when you use air pollution data, what lag time are you using? Are you using 10 days before, a month before, a year before?
So actually, we took monthly average. So
I see.
when we made, that's because we made analysis over like 15 years period. So this is not like time series analysis with every day, like exposure, something happened, over the day, and then they have like 2-3 lag period or week lag period. We have different study design and different purpose. That's also type of time series analysis, but it includes monthly averages. So first we averaged monthly health data, monthly air pollutant data, and for monthly, so we decided that probably we shouldn't worry so much about certain lag period, even when within these months we had some acute event of higher level of air pollutants. So it's a little bit different approach to analysis, which usually they're publishing like time series with everyday fluctuations. But we took, because of such a long time scale, we took monthly fluctuations. And another thing I just wanted to add, it's not about only your question, but in general. Now there are more and more discussions that probably we shouldn't move from each air pollutant health impact to combined air pollutant, so-called multi-pollutant modeling or multi-pollutant effect. And because a real person lives in real life where at the same time we have in the air all these air pollutants and something else. So that will be also one of the next steps to look at real exposure. That's mean multi-pollutant approach and model this multi-pollutant level and look how combined it could affect or improve, in case of decrease, improve the health of population.
That actually leads to my next question. So in this table, the model you use, are those single pollutant models?
Yes. In this case, yes, single. So because first we want to understand that there is some impact here, and we really see, this impact, even it's larger from 2.5 particulate matters, which is in agreement with other publications and our understanding of mechanisms of potential health impacts from particulate matters, 2.5. So, but the next step from each pollutant, one pollutant modeling will be moved to multi-pollutant modeling.
And I also appreciate that you use both correction. Is that correcting for different pollutant disease combinations?
Yes. You see, it's 10 minus 6 degrees.
That's
so
pretty significant.
it's very, because we multiplied all outcomes, all diseases, so that's pretty strict, but we selected just results which passed this correction criteria.
So my last question is that regarding the time scale, we were talking about the lag time. In the table, you use a month previous to when the data is collected for hospitalization or mortality. So my question is that when you look at this table, it shows us a very good summary of how acute health outcome of air pollution exposure can change the mortality and hospitalization for cardiovascular diseases. My question is that it seems like it's a trigger. When I look at the disease itself, we look at myocardial infarction or hypertension or ischemic heart disease. All of those are chronic conditions, and all of those might include some kind of vascular changes, maybe some buildup of atherosclerosis it's a chronic process, pathology and physiology-wise. So my question is that, do you have long-term data of people's exposure to air pollution and then correlate with that with the hospitalization and mortality data?
So again, we did not take into account in this analysis how many years people actually lived in this area under the known level of air pollutants. We just looked in general if there is some correlations. Now we see there are some correlations. Now we have the options in the data, like check this more detailed information, like for example using Medicare files, which I mentioned before, with precise individual records. Because yes, that's mostly, like chronic conditions. And we just assume that people lived here under this air quality for many years before they developed all these consequences, or they became, feeling better in terms of cardiovascular diseases because of better air quality. But now in this study, we just, averaged by, residence, county, address, and we did not take into account specific information because we did not have it in these data files. So we need to use other data files, what we're planning actually to do, other data files to take that into account.
Did you do correlation with ozone also, or?
We did not include ozone here because we got for ozone very unstable results, and it's very important to know where, in which height, like these people lived here. So we are not ready right now to discuss all details with ozone because it's very specific, pollutants. So that's why here we just showed these four, which are easy to explain and easy to analyze in terms of health impacts.
Thank you.
Hi, Elizabeth Kamai from UNC Epidemiology. I was wondering if you could connect this at all to policy changes. The prior speakers talked a little bit about the potential for a natural experiment with the Clean Smokestacks Act. And you only have data presented from 2000, but is there an opportunity to look at changes in time prior to the implementation of this policy, and if associations are different before and after?
Yeah, that's a very good question, and that's really what should be result from our work. It's really to suggest something to policymakers. At its current state, about these results, we can definitely say, yes, there is some beneficial impact on health for these diseases, for these disease groups. And we can really say that even in North Carolina, when we have now cleaner, much cleaner air than we had 20 years ago, we still have something to improve, because we could expect, if air will be cleaner, we could expect some positive impact on cardiovascular diseases. But to make final suggestion for policymakers, we also will be happy to finalize also better treatment option analysis. So like because it goes together, we have better air quality, we have better treatments for these diseases. And to tell exactly which percent is because of better air quality, we need clear understand which percent is better because of better treatment, because we can account what we did for smoking, for social economic characteristics, for example, for monthly fluctuations. But Generally, right now, we can just tell, yes, here is something here we need really to pay attention to. Yes, we have some positive impact. Now it's evaluated like this one. After additional evaluation of treatment, so we will show exact percent which is dedicated to air pollutants level.
Julia, you're going to give a couple talks during the forum, and some of the other talks you really focused on the source of pollution, whether it's a CAFO or a coal ash, and then you map the events in their relationship to that source of pollution. What about the source of pollution now from coal-fired power plants? Is it possible to look for more events around those plants? Do you think that the pollution plumes, if you will, are so broad that it's hard to do that? What do you think about I guess they got rid of the coal-powered power plant next to Duke Hospital. I guess they replaced it with natural gas. But should they be measuring around hospitals, these types of things, or where this type of pollution is associated with acute events? Is that something that should be considered?
Mm-hmm. Thank you for this question. Yes, tomorrow I will also present presentation on HOX CAFOs and then another presentation on coal ash and Alzheimer's disease risk. So because we simultaneously analyzing multiple potential sources of health impacts, exposures in North Carolina. And now we can tell that if we look at the maps, there are some counties where we have simultaneously coal ash, we have multiple HOX CAFOs. So we have certain air quality because probably transport, like cars, something like this. So we have in North Carolina very heterogeneous picture of sources of pollution, of air pollution. So that's why I mentioned before that one of the next steps will be to estimate these impacts in different parts of North Carolina, because there are parts with HOX CAFOs and coal ash. There are parts with coal ash. There is, Appalachian region with very specific weather conditions. There is eastern region with very specific weather characteristics. So yes, it could be that in different parts of North Carolina we'll find that different sources contribute to health impacts. As to the impact of coal ash specifically on cardiovascular diseases, so it looks like it contributes to cardiovascular diseases of residential populations, but right now we cannot say that it's one of the most prominent impacts. So that's why tomorrow we'll mostly talk about Alzheimer's disease and potential toxic impact on human brain. If we could regulate air quality around the coal ash, it will be beneficial, definitely, not only because of cardiovascular diseases, but also because other diseases which could be largely associated with, especially for nearby populations who are living like within a couple miles from here or working a couple miles from here. Of course, that's one of the points of discussions and future studies. Yeah, please. Mm-hmm.
Did you have a chance to observe how these correlations changed by season and by socioeconomic level? And my question goes to an observation I heard from epidemiologists a few years ago about how these health events are more likely to occur in low-income populations when there is intense heat and humidity, or when they cannot meet their energy needs. Mm-hmm.
Yeah, thank you for this question. We have in our data set information on weather, including heat, temperature, humidity, wind, all these factors. And especially it's important for summer in North Carolina. And we can tell, as I mentioned earlier in my presentation, about higher strokes level, especially among younger people during heat season in North Carolina. And we also see on slides these red dots. It's mean summer season. Particular matters are higher in summer season. So we definitely will do a next analysis on factors which affect human health from environment in summer season, especially because for North Carolina it's no wind here, high humidity, and health impacts specifically for this season. But as to social economic factors, we adjusted here for social economic factors, but we also could look at specific groups of populations, which are especially like with low income. But again, as I mentioned at the second slide, that after adjustment by social economic factors in the US, we still have huge difference between disease risk and mortality and life expectancy. So yeah, that's one of the factors.
Right, but what I think is very interesting to look at is whether there is the risk of overstating these correlations, because the same days when we have high concentrations of these pollutants are the days when electricity demand is the highest, and when the most polluting power plants, the oldest coal-fired power plants that should be retired but are not because they run 4 hours a year, etc., are running. So it may be that those days when you see a high correlation between the mortality and the pollutant is not necessarily so much because of the pollutant, but because of the lack of electricity, or this low-income population not being able to cool their homes or having to work outside under the terrible North Carolina's humid
that's
summer.
correct. But we took monthly average, just not the. But when we took monthly average in this design of the study, so we just pretty much averaged over the month. So extreme peak of particular matters, for example, levels we little bit downplayed with this scenario. Just try to average.
Well, again, I think we're hearing, again, some really great perspectives and guidance about strategies in which we can use the natural experiment. Are there regions of the country in which the legislative impact wasn't felt because perhaps they were using a different source of energy? Or are there other ways to really look at this data? Or what are the comparator populations that could perhaps isolate the air quality and so forth? So I think, again, these are works in progress. We are definitely hoping to engage and facilitate conversations and collaborations between individuals. Julie, I think you did a great job, again, giving us an update from the respiratory disease and really bringing up the issue of other diseases, including cardiovascular effects. We have a break now for about 15 minutes, and so I think we're going to reassemble at 3:15, and we'll hear Sheila, who I'm sure will give a masterful discussion of what has happened and what we hope will happen in the future.